You know, since most people in this country have some form of health insurance, I decided, after many calls from constituents that have said to me, I can't afford a 20% increase in my medical health insurance premium. I had a 10% one last year. I began to look into the history of the medical insurance industry in America. And so I've come to the floor to discuss the current state of the private, publicly owned, for-profit health insurance industry and the ways this system, I believe, must be changed during healthcare reform. Bottom line, our country is the biggest healthcare spender in the world. In return, we get very average results. And it wasn't always this way in America. I'd like for a moment to briefly review the history of health insurance in our country, because understanding its development and its transition to the for-profit commercial health insurance model is actually critical to this debate. The story really begins to take shape about 90 years ago. There were very few health insurance plans before the 1920s. As a matter of fact, there was not much in the way of medical services to insure. Options for medical care were primitive by today's standards. In 1900, the average American spent $5 each year on healthcare-related expenses. This amounts to roughly $100 in today's dollars. Health insurance was not necessary because the cost of care was low. Over 90% of medical expenses were paid out of pocket. Most patients were treated in their homes, and medical technology and treatment options were very limited. The earliest private health insurance plans in the United States were fairly basic agreements, primarily sponsored through employers or unions. Employers deducted funds from participating workers' salaries and contracted with local physicians for treatment. During the 1920s, medical technology was advancing, and the treatment of acute illnesses shifted from homes to hospitals. But on the heels of the Great Depression, an increasing number of Americans were unable to afford medical services, which were becoming more costly. In 1929, the Baylor University Hospital developed a plan to guarantee affordable treatment options for patients while ensuring a steady stream of revenue for the hospital. The Baylor plan provided up to 21 days of hospital care and certain services to 1,500 local teachers in Dallas, Texas, for $6 a year or 50 cents a month, if you can believe it. A hospital official promoting the plan at the time said, and I quote, "We spend $1 or so at a time for cosmetics and don't notice the high cost. The ribbon counter clerk can pay 50 cents, 75 cents, or $1 a month. Yet it would take about 20 years to set aside enough money for a large hospital bill." The Baylor plan proved popular and was soon expanded. It served as the foundation for what would become Blue Cross, the first example of a major nonprofit medical insurance provider in our country. Throughout the 1930s, the number of Blue Cross plans grew and enrollments expanded. By 1937, 1 million subscribers were covered. In response to the lack of coverage by Blue Cross for physician services, in 1939, the precursor to Blue Shield, called the California Physician Service, was developed. This plan reimbursed physicians for the cost of services based on negotiated payment schedules. In 1945, nonprofit Blue Cross and Blue Shield plans had expanded to cover 19 million subscribers nationally in most states. These nonprofit Blue Cross and Blue Shield plans dominated the health insurance industry. At this same moment, Congress was reviewing the matter of insurance regulation generally. In 1945, after significant lobbying by the industry, the McCarran-Ferguson Act was enacted. By passing this law, the federal government committed to a hands-off approach to insurance regulation generally, including the regulation of for-profit commercial health insurance companies. And this is where things began to change. The McCarran-Ferguson Act gave states, not the federal government, primary responsibility for overseeing the insurance business. It meant, as a practical matter, that whether insurance companies would be regulated forcefully or with little care would be left up to individual insurance commissioners in each of the 50 states. Additionally, the McCarran-Ferguson Act included a specific antitrust exemption for the business of medical insurance. As a result, practices like price fixing, bid rigging, and market allocation that were prohibited by federal law in every other industry were left up to the states and their enforcement mechanisms. If insurance companies colluded to raise prices above competitive levels, federal officials would not and could not investigate or intervene. All regulation was up to the states, and in fact, very little regulation has taken place. During World War II, for-profit employer-based health insurance plans expanded rapidly and took a firm hold in our country. Due to price and wage controls, employers competed for workers by offering health insurance benefits. In 1944, the unemployment rate was 2%. Additionally, unions were able to collectively bargain health insurance benefits and employer contributions for health insurance, which were excluded from a worker's taxable income. By the 1950s, for-profit commercial health insurers, such as Aetna and Cigna, became very active, and then things really started to change. The market share of Blue Cross and Blue Shield was significantly reduced in many parts of the country. As of 1953, commercial insurers provided hospital insurance to 29% of Americans versus Blue Cross's 27%. The widespread entry of commercial insurance into the health insurance market had a dramatic impact. First, the commercial health insurers did not operate under the same rate restrictions as Blue Cross. Second, Blue Cross premium rates were based on the average cost of medical services in a defined geographic area or community. Commercial insurers, on the other hand, calculated premiums based upon the claims of particular groups or individuals and adjusted these premiums each year depending on their health status. This also allowed commercial insurers to evaluate coverage on individual rather than use the community rating system of Blue Cross. Therefore, commercial insurers were able to underbid Blue Cross for firms with very healthy workers, which were cheaper to insure. So right then and there, you began to see the skewing of the system away from a community rate toward an individual assessment whereby companies could cherry pick only the healthiest and therefore make more money. The loss of these healthier groups then raised average costs among the remaining employees, placing Blue Cross at a competitive disadvantage with commercial insurers. This competition from commercial insurers eventually resulted in Blue Cross changing the way its premiums were calculated. So the single community-wide premium pricing model was replaced in favor of the commercial approach. This shift toward charging premiums based on claims of particular groups or individuals changed the nature of the competition in the health insurance market. Insurers could reduce costs by shifting risk and recruiting employers with healthier workers, and they did. Furthermore, because they could choose whom to insure, many large for-profit commercial insurers left the individual market altogether in favor of large-scale employers because they carried lower operating costs. So where does that leave us today? Today we have a health insurance industry where the first and foremost goal is to maximize profits for shareholders and CEOs, not to cover patients who have fallen ill or to compensate doctors and hospitals for their services. It's an industry that is increasingly concentrated and where Americans are paying more to receive less. Here's the bottom line. In the last 9 years, American families have seen their health insurance premiums more than double, while benefits have been getting worse and the industry has been growing less competitive. A snapshot of the American health insurance industry today presents an alarming picture. As of 2007, just 2 carriers, WellPoint and United Health Group, have gained control of 36% of the national market for commercial health insurance. Both of these companies had more than doubled since 2000. Since 1998, there have been more than 400 mergers. That's in 11 years. 400 mergers of health insurance companies as larger carriers have purchased, absorbed, and enveloped smaller competitors. In 2004 and 2005 alone, this industry had 28 mergers valued at more than $53 billion. That's more merger activity in health insurance than in the 8 previous years combined. Today, more than 94% of American health insurance markets are highly concentrated under U.S. Department of Justice guidelines. Excuse me. This means that these companies could raise premiums or reduce benefits with little fear that consumers will end their contracts and move to a more competitive carrier. In 10 states, Alabama, Alaska, Arkansas, Hawaii, Iowa, Maine, Montana, Rhode Island, Vermont, and Wyoming, these 10 states, 2 health insurance companies control 80% or more of the state market. So 10 states, 2 health insurance companies control more than 80% of the statewide market. In my state of California, nearly 40 million people, just 2 companies, WellPoint and Kaiser Permanente, control more than 58% of the market. The market presence of these 2 companies is a combined 14%, is up a combined 14% in 1 year. Let me repeat that. The market presence of 2 companies in California is up 14% in 1 year. When you look at specific health markets, the situation is even worse. In 2007, the 2 largest health insurance companies in Bakersfield, California, controlled 76% of the market there. In Salinas, the top 2 controlled 65%. And in Los Angeles, the top 2 carriers controlled 51% of the market. This is a huge market. It's a 12 million person market. And 2 companies control over half of that insurance market. The American Medical Association described it this way, and I quote, "The United States is headed toward a system dominated by a few publicly traded companies that operate in the interest of shareholders and not primarily in the interest of patients." I think that's a very sobering statement. The effects of this market concentration are being felt by consumers and families. They are being felt by American businesses, and they are being felt by doctors and healthcare providers.